Oh no, I didn't.
I watch them.
Yeah.
I do,
I didn't.
Professor.
I just watch it from YouTube.
I watch them.
Yeah,
Okay.
sometimes I go on YouTube and I just search it directly.
Of
All right.
course, Professor. That's how we knew
I
it.
don't
It
follow
said
the link.
something about nothing.
The what?
I said that's how we knew the name of your thing was something about nothing because we actually watched it. Or nothing to see here, something like that.
Oh, my name. Oh, okay. All right. Okay,
Yeah.
let's start with Guillain-Barre Syndrome. So it's always nicer when you
Oh,
pronounce it the way the French intended.
we can't
Oh, you
see a
can't.
screen.
Oh, you can see it now.
Yes.
All right. So Guillain-Barre Syndrome. It's French. You know, it sounds better if you say Guillain-Barre. Don't say Guillain-Barre, but you say Guillain-Barre, like Ménage à toi and what else? Yeah, whatever else is French. Okay. So this is a peripheral nervous system disorder. It's not going to occur by itself. It's usually a complication of a viral illness. Other diseases like Campylobacter infection can also trigger it, but the most cases are triggered by some sort of viral illness. Either you got sick with a virus like the flu, or even if you got the flu vaccine. There are instances wherein it occurs 2 weeks after someone got a flu vaccination. It's quite rare. It's not like everybody's gonna get Guillain-Barre by getting the flu shot. It's quite rare, but it's dangerous nonetheless. This can kill patients. The manifestations are characterized by weakness. So if you remember in myasthenia gravis, wherein we had myasthenia gravis last semester, correct? So there was progressive weakness with any repetitive activity, right? If you had any repetitive action or repetitive muscle contraction, there was progressive weakness, and then it was improved when you took a rest. So when you rested, your strength came back. This one starts from the feet. So the weakness here is ascending weakness and paralysis, and then it can reach all the way to your diaphragm, and at which point, if it happens, then you may have to be intubated and put on a mechanical ventilator. So the important part here is when symptoms appear, the patient should go seek medical attention, because if we catch it within 2 weeks of the onset of symptoms, we can stop the progression. That way you avoid intubation and mechanical ventilation, or possibly dying from this complication. As I mentioned, these are the usual triggers. The patient has any respiratory or GI infections. Campylobacter is most frequent. You also have the flu, as I already mentioned. So it's caused by autoantibodies. So following the trigger of the insult, which is again the infection, your body starts making these antibodies against your nerves, causing the weakness. The patient's main complaint is acute lower extremity weakness. No reflex. So when these patients get up, I had one big guy have this, and he described it as he just got up one morning and he got up out of bed and stood, and then he just fell to the ground because it looked like his legs were like noodles. Okay, so his legs, his feet just went limp, and he could not support his weight. And it just got progressively weaker over the next few days. So this is the problem here. So we developed autoantibodies, obviously this is an autoimmune disorder, attacking your nerves, causing them to have demyelination. So myelin sheath is you can compare it to an electrical cord. This would be the covering of the electrical cord, allowing impulses to travel seamlessly from one neuron to the next, allowing motor function to be possible. However, since the neurons specifically, are demyelinated, so therefore can impulses travel smoothly? They cannot. So therefore no myelin, then no impulse, no electrical impulse, no stimulation to the muscle will not contract. We don't have to test regarding the stages because the course is predictable. The patient will go through acute, the plateau, and then the recovery phase. The important thing here again is to catch it early so that the patient seeks medical attention, and we can shorten the course of the illness. So we shorten it, and then the patient will recover faster. Without, again, we want to avoid or eliminate the need for intubation here. Yes. A few cases, like I won't say the name, but we did have a faculty member here at Swedish Institute who developed Guillain-Barre Syndrome. She had the flu, and then 2 weeks later, she had the symptoms, and luckily she's a nurse, so she's aware of what's going on. So she went to the hospital, and then she got the immunoglobulin treatment, and she was better. She was able to go home. She regained function. However, she had a setback. She developed a complication from Guillain-Barre syndrome called a polyneuritis. So today she still has residual weakness. She can walk, but not like she used to. So she's now pretty much, if she goes out, she has to be on a electric scooter now. And since that, she tried to come back to work, but it was just a lot of hassle with the trains and having to, drive and then modify the vehicle to accommodate her. So she just went on disability now, which is what most people in that situation. How can you, with our line of work, we can probably do that if we were in a rural community, but in the city, it's really difficult, even though we have disability accommodations. We have ramps, we have elevators, but just difficult to get around. So the classic symptoms again is progressive ascending paralysis, weakness and paralysis. So starts with the feet, and then as you go through the stages, it goes progressively up up to your knees, then your thighs, and then the pattern again will reach your your diaphragm, at which point your vital capacity will drop because of course your diaphragm weakens, and then you cannot breathe anymore. So here, starts in the toes and up it goes, if that helps you remember. Other manifestations are related to autonomic dysfunction, such as dysrhythmias. So this is outside the motor paralysis, weakness and paralysis. So the patient will have hypotension, paralytic ileus, urinary retention. So it affects, as it again goes up your body, it will cause problems along the way. It is diagnosed by CSF analysis to look for the autoantibodies, and also your history. Again, usually the patient has some recent viral illness um, or the Campylobacter infection recently, preceding the symptoms. There are other tests that's going to be done, like a EMG, for instance, right here, electromyography, but they are not used to diagnose Guillain-Barre syndrome. It's done more like to rule out other causes because these symptoms resemble spinal stenosis, for instance. Say you have a pinched spinal nerve, it can also produce similar symptoms. So to rule out that it's not caused by a spinal injury, they do the EMG test. Have you ever seen an EMG test? It's tedious. It takes a long time, but they use tiny needles, but the needles do not cause any bleeding. Okay, they do pinch, right? Yeah, painful. They just put 2 needles at a time, like one proximal, one distal. It's done by a doctor, and what they're doing is to see whether or not there is. They pretty much put, let's say, one needle is on the proximal part of your thigh, and then the other needle is down your leg near the ankle. And then when they put electrical impulse there, they want to see if the impulse travels from the thigh to the leg, meaning they're trying to see, is the myelin sheath intact, meaning can the electrical impulse travel from the proximal to the distal nerve. If it travels, then it's not Guillain-Barre. Does that make sense? Meaning there is still myelin sheath there. So your problem is probably caused by something else, not a demyelination problem. Does that make sense? Okay.
Yes, because what I'm trying to say, demyelination is called, if you have demyelination, that means to say you have GM syndrome.
Mhm.
That's what I mean.
Say again?
Demyelination.
Yeah, I mean, if there is demyelination, meaning when they put the electrical impulse from the proximal, there will be no, it will not travel down the distal because there's no myelin. So if that's a positive test, then you have Guillain-Barre syndrome. There is demyelination of your nerves, of your neurons. All right, now let's look at the treatment. Within 2 weeks, again, the key here again is the time. There has to be no more than 2 weeks. If you get to your doctor within 2 weeks of the symptom onset, there are two modalities here. We can do immunoglobulin infusion. It should not really say N. I think the way they said it is there are two approaches here. Either you do IVIG and plasmapheresis, but don't think about it as you're getting both. Is that clear? Hey, team nurses, is that clear?
Yes.
Yes.
All right, you don't do two, okay? Because it's like um, taking Tylenol and ibuprofen, which each one is just as effective. Does that make sense?
Yeah.
Yeah. Okay, so let's take a look at each one. So it's an autoimmune disorder, correct? So almost all autoimmune disorders, the symptoms are caused by autoantibodies, meaning it's your own body producing antibodies against your body, in this instance against your neurons, causing the symptoms. So we want to stop these antibodies from being produced or totally eliminate them. So one way, which is very, very expensive, is IV immunoglobulin infusion. So this will be given over a period of weeks. If you have good insurance coverage, then you can get this treatment. It has the least amount of side effects. The most side effects here come from, let's say you have a allergic reaction, you react to the substance, the solution in the used in the IVIG, but it's very, very expensive. This is sold by the gram, meaning the pharmaceutical company will charge you per gram, and it's based on the dose is based on your weight. So the heavier you are, the more you'll get, the more doses, I mean grams you'll need, and it's about 1,000 to 1,500 per gram. So a treatment, so for if you let's say weigh 60 kilograms, you could easily pay anywhere between 20 to 25,000 per infusion, and you're gonna need probably 6 to 8. So how much is that?
A lot of money.
About 200 grand.
$200,000.
Yeah, yes, about 200,000 just for treating. Okay, and this is doesn't include your hospital stay, etc. Right, so it's quite expensive. The alternative is plasmapheresis. Plasmapheresis is like dialysis, so you'll still need a large catheter inserted as your access, just like dialysis. So we'll remove your blood, put it into a machine, an apheresis machine, and then it returns back to you. What's it doing in that machine? It's removing stuff. So let's say you're donating platelets, same machine, it's going to remove only platelets. You're donating platelets, they'll return your red blood cells back to you. In this machine, an apheresis, plasmapheresis machine, they're going to remove your plasma. Why plasma? Why is it removing your plasma? That's where your antibodies are found. So plasmapheresis, therefore, is a process wherein it's the technical term is plasma exchange. So we'll remove your plasma and then give you another person's plasma in exchange, hence called plasma exchange. There's also an alternative for less stable patients. Plasma exchange might cause more problems. So what they'll do is remove less plasma and exchange it with saline instead, allowing your body to replenish the lost plasma. Does that make sense? So these are the two main treatments here. Again, it's or. Either you get plasmapheresis or IVIG. Main difference between the two, IVIG is easier but very, very expensive. Plasmapheresis, very inconvenient because you have to go to like dialysis several times a week. So many sessions. There are complications, of course, because you just concluded hemodialysis last semester. So it's like that. So you're removing plasma, and we'll talk about some complications of plasmapheresis shortly.
You said that when you do plasmapheresis, they're getting somebody else's plasma back, or they're just kind of
Depends. Again, if it's plasma exchange, they're going to remove your plasma. And then, sorry?
How often did I do plasma?
2-3 times a week, similar to dialysis.
Professor,
Yes.
I have a quick question
Uh-huh.
in relation to something that you had said. You see how you said that you're not supposed to give Tylenol and ibuprofen?
Yeah, together, because basically they work the same.
Because when I was at the hospital, they gave me Tylenol, and then like 15 minutes
But
later, I got ibuprofen.
yeah, but not at the same time, right?
No. Okay.
Yeah, and you were probably crying like a baby. That's why they gave you two. Is that what happened?
I was complaining. Not crying, just complaining.
Yeah, that's probably that's why they gave. Yeah, just to shut you up. Okay, look at this here. So cost-wise, look at this, 2 grams per kilogram. So like I said, it's about a grand, maybe $1,200 per gram. Times 2, that's 2,000 times 60. Oh man, this is even more expensive than I thought. So forget the 200 grand. This could reach around 500,000 potentially. So I sounded really cheap there when I gave you 200,000. No, it's But there'll be no math question on this, okay? We're not the ones calculating the cost here for the patient. That's between you and your insurance company. So just think about, you know, if you have a, because this is now a pre-existing condition. So will the insurance cover this? No, you're gonna have to sell your house to get the treatment. Okay. Anyway, so I'd like to emphasize only one of the two, right? So you either get IVIG or plasmapheresis, and that can get you back walking within 2 to 4 weeks. Right? Very effective. If you go beyond 2 weeks, you wait too long for treatment, they won't even bother with the plasmapheresis or IVIG. They'll just say it's too late. We're gonna just have to do this symptomatically. We'll just hope for the best. They'll intubate you if needed. Okay, so they'll have to treat you symptomatically because research shows it's not going to benefit you if it's beyond 2 weeks. It's basically too late. We're wasting money if we're going to. Yes.
I was going to ask, you said they have to get this done about 6 times. Does that mean lifetime? Like
Oh, no. Just for that period. That's it.
Okay.
Yeah.
So after that, what they just look like a vegetative state at that point?
What do you mean if it's too late?
Yeah.
I mean, it will stop on its own, meaning it's a viral, you know, it's a viral complication, meaning this is a self-limiting event. But the question is if you're going to survive it. Because after you get intubated, so we don't know how long you're going to snap out. Plus, there's complications related to intubation. So if needed, these patients may be on trach, you know, if they go beyond 2 weeks and they show no improvement. So it's really important that they seek medical attention. Now that's easy for someone who has insurance. If this happens to somebody who's uninsured, they most likely will just lay down at home and not go to the hospital. So here again, so emphasize within 2 weeks. Okay, that's the magic number there. You have to do it within 2 weeks. Okay, let's go now to complications of plasmapheresis, which is here. Adverse reactions to plasmapheresis. Now, imagine removing plasma. So you will lose osmotic pressure there. So what happens to blood pressure first? Hypotension will result. Along with that will be bradycardia. Infections can occur because of your, not all antibodies are bad here because it's really the auto antibodies that we want to remove, but they're mixed all in there. We don't have the capacity to just remove those bad auto antibodies causing GBS. So all antibodies are removed here. So that's why you're at risk for infection at the same time. What else is in plasma? Is it only protein and antibodies in there? Yeah, and we did that with, yeah, that's why you're at risk for infection. Here, why do we have
Clotting
bleeding?
factors.
Okay, we have clotting factors in the plasma also. So if you remove all that, then you're at risk for bleeding as well. So it's not easy peasy. So that's why I'm I'm biased toward IVIG, because the IVIG, you only side effect is really, which is rare, is you have a reaction to the IVIG. But plasmapheresis here, plus it's not a one-time treatment. This is going to be several treatments. So these are your possible complications here. There's hypocalcemia because this is related to the procedure. When the blood leaves the body to go to the machine, the tubing has citrate in it. And the hypocalcemia here is related to citrate toxicity, because as your blood, they don't use heparin, they use citrate. So as the blood leaves your body, to prevent it from clotting in the tubing as it goes to the machine, they have citrate there. Citrate is like a preservative, so no clotting occurs, but you're receiving citrate. And then once citrate enters your body, it binds automatically with calcium. So now you have calcium citrate, which will go to your bone leaving you with less free calcium. So you know the calcium, the ionized calcium, the calcium that goes in and out of the cell drops because where did they go? They went with citrate. You know, they went eloped with the citrate. So every citrate molecule that enters, they elope with calcium. So now you have less free calcium, leading to hypocalcemia. And that can lead to your cardiac dysrhythmias,
Did you
right? Weakness, etc.
put that like on a drip or something?
Yeah, eventually we're gonna have to treat the hypocalcemia.
So you wouldn't treat it while you're giving?
Because it'll just go to the, I mean, yeah, you're just creating more calcium citrate, if that makes sense. So we'll have to do it after the treatment, not during.
Professor, I have a quick question.
Yes.
The heart problems, like the cardiac arrhythmias, can any of those be permanent?
Only because you have the hypocalcemia.
Okay.
Yeah, but once you resolve that, then you're good. All right, so for patients who do have the weakness ascending all the way to beyond the lower extremities, so we now have swallowing problems here on top of the breathing problems. So we'll have to modify the diet. Plus, you saw the weakness will also affect your GI motility. So we'll have decreased gastric motility, dysphagia. So modifying the diet is necessary so they're easier to chew, easier to swallow. And then, of course, if the patient does get intubated and on a vent, then we'll move to tube feeding now. And please review. I think we did this last semester. Yeah. Okay. So we can skip through that. Other complications are related to the immobility. These patients are bedbound. Remember, the IVIG or the plasmapheresis won't magically erase the symptoms the minute you receive it. It will just, what is the purpose again of the treatment? It will shorten the course. So a few weeks, so until 2 to 4 weeks when you can be walking again. So for those 2 to 4 weeks, you will be bedbound. Okay, you will have extreme weakness, so you'll have immobility, then you could still die from a DVT or a PE or get pressure ulcers. So we'll take care of that. Again, we'll have to wait for that time. Time is, it's a waiting game here. And hopefully you won't have any further complications and that the IVIG and um, plasmapheresis will do its job. So 2 to 4 weeks, you'll be back on your feet. Here are our main summary signs and symptoms again. And here are our diagnoses. Because ABC, that's why you have ineffective breathing pattern as the priority there. There is some pain. And the rationale is they think it's the sensory nerve fiber involvement. I don't really know if that's the only cause. Yes.
They are experiencing their pain like that, like after the fact. Could you give them something like gabapentin?
Yeah, right here. So for the pain, we use because the pain is neuropathic in nature because it's the nerve here that's painful. It's not somatic, so opioids won't be effective here. So good question. We'll be using anti-seizure medications or maybe antidepressants as well. So turn frequently and then DVT prevention. All right, communication can also be difficult, especially if the patient's already intubated. So here are your, give him a Ouija board or something to communicate with. And teaching. So educate the family about what's happening. Again, if this, maybe they'll have another family member who could get it because autoimmune diseases, if you have one, one member, maybe another member will have, another, because we don't know what's causing autoimmune diseases. That's why we have no cure for these things. And that's it. Any question on Guillain-Barre? So on top of this also, if you have a lingering viral illness, then that will also be treated on top of Guillain-Barre management. Any questions? Very good, children. Let's go straight to thermoregulation now. Yes. As a complication of plasmapheresis, yes.
So why would they need to be on
Well, there are only, not all clotting factors are removed. Plus, clotting factors aren't the only ones that will form a clot. I mean, you have platelets still. Platelets aggregate whenever you have venous stasis. So there you go. Okay, why are we in intraoperative chapter? Well, we're not doing intraop. We're looking at the complication of anesthesia. We are on page 299. We're not doing the entire complications of general anesthesia, only malignant hyperthermia. So the next module is a failure of thermoregulation. So let's begin with malignant hyperthermia. This is the high spectrum of the thermoregulation, meaning the patient develops severe high temperature. All right, so what is malignant hypothermia? It's a hypermetabolic state. This still involves the muscles. This one, though, is genetic. It's not autoimmune. This is an inherited muscle metabolism disorder. The trigger is general anesthesia, as well as a neuromuscular blocking agent. Okay, so not all general anesthetics are triggers, but the most common ones are the cheapest ones. The most commonly used inhaled gaseous general anesthetics, namely ensoflurane, desflurane, which are commonly used for almost everybody. That's the treatment. Yeah. So the trigger again is most of our general anesthetics, again, those that end in flurane, desflurane, ensoflurane, halothane also are all the triggers. So all our most commonly used volatile gas general anesthetics are the trigger. And like I said, the neuromuscular blocking agent, succinylcholine. It's not an anesthetic. So in anesthesia, you typically receive 3 drugs. Because we can't have you just unconscious. We have to paralyze you, because it will be disastrous. Because when you're unconscious, do you have control over muscle movements? No. Who knows when you're gonna pick your nose in your sleep, right? So we have to paralyze you to make sure you don't move. Because what happens if we're cutting something and then you twist and you're dreaming and then you move? So that would be a disaster. So we give you a muscle paralyzer to make sure you do not move. And then of course the third agent is a pain medication, because it's painful and you can't tell us you're in pain because you're unconscious. So the anesthetics here and or the succinylcholine are the triggers. So what happens is your muscles react to these substances. What happens is you go into in a hypermetabolic state. How does the body generate heat? In winter, how do we, let's
by
say,
shivering.
okay, so shivering is a form of muscle contraction, correct? Yeah, when you shimmer, it's like you shimmer there. Yeah, okay. So muscle contraction is how we generate heat. Now imagine if every single skeletal muscle in your body, from your head to your toes, contract and never relax. How much heat are you talking about here? How much heat are you generating? This patient goes, the temperature can get and reach up to 111 degrees Fahrenheit here. In such a short time, within a few minutes, the patient's, because of the muscle rigidity that occurs, the patient's temperature rises. However, that's the least of your problem, because this is actually a late sign. The heat here will probably be 15-30 minutes later. In the meantime, many other problems occur before the temperature reaches 111. What are these problems? So, can a sustained muscle contraction have no injury? I mean, try holding up a 1 liter bottle of soda. Israel, you're a strong man. You can hold that up, right?
Yeah.
Yeah. Try holding it for 6 hours.
Nah, my shoulder
Can
would
you?
start hurting.
Yeah, that's a different story, right? So imagine your muscle thing, but they have no ability to relax. The muscle contraction here is sustained. So does the muscle last long?
No.
Do you have enough oxygen to supply every single skeletal muscle contraction?
Nope.
No. So you switch from aerobic to anaerobic metabolism. What is the consequence of that now? Acidosis. You go into lactic acidosis, right? So here are our problems. So we go into acidosis. This is from lactic acidosis. The hypoxemia triggers sympathetic nervous system, so that's why your heart rate rises, and of course your oxygen level drops, so your CO2 rises, and glycolysis, because again you're in a hypermetabolic state, and then hypoxemia, hypercarbia, hypoxemia, and then this is again the late sign will be hyperthermia. On top of these, when muscles die, what do they release into the bloodstream? Potassium. So do we have hyperkalemia here? Yes, the number one killer here, if it's not really hyperthermia. If the patient survives long enough, yes, they'll die from hyperthermia, but hyperkalemia will kill them first. So either acidosis or the hyperkalemia will kill the patient. They go into cardiac arrest before you even see the hyperthermia. Or at that point, the hyperthermia won't even occur because the patient's dead already. Yes.
What level of potassium would it take to kill a patient?
More than 7. Well, I can't really tell. I mean, patients who've had cardiac arrest, they had it at 6.8, because each person tolerates dysrhythmias differently. Same thing for hyperkalemia. We don't really know. Some already have PBCs at, I don't know, 5.9. So we don't know. I mean, I can't really say when. Oh, when the muscle cells die, okay, so they release potassium. What else, by the way, there's one more thing. Besides potassium, when muscle cells die, what else is in muscles specifically? In skeletal muscles, when they're destroyed, when they die, what else do they spill out? Yeah, we have lactic acid already. Then we have potassium. Something specific to muscle.
What?
Is that the tip of my tongue? Can you read it?
Nope. Wait.
Is that
Yes, what is it?
Vitamin D.
No. M and Y.
Bone marrow. No.
No. MY.
Myoglobin.
Okay, myoglobin. So there's also myoglobin here. So when muscle cells die, they spill out lactic acid. We have potassium, and now we have myoglobin. What will myoglobin in high amounts do to your kidneys? We had this last semester in intrarenal AKI.
It would like,
From hemolytic anemia, that all kind of.
it could damage your, it could damage
Okay,
your,
it will go into intrarenal acute kidney injury, right?
yeah.
So here's another cause of death. So add it there. Now acidosis, hyperkalemia. Then what else did I say?
Lactic acid.
Yeah, hyperkalemia, and then the acute kidney injury now. Okay, so pick which one do you want to die from. So all of these are possible causes of death. That's why I'm saying hyperthermia is probably the least of your problem, because they may not even reach that stage. Okay, the patient's dead before hyperthermia sets in. If you have, I mean, it's very rare. I mean, plus we do our good question. We'll talk about prevention later. Let's finish management first. Okay. So the most specific sign is muscle rigidity. However, stay here. However, there's a big however. The first sign noted is really cardia. Other textbooks, the first sign, they're pointing toward unexplained hypercarbia, not tachycardia, which I'm biased toward, because I mean, this patient will have tachycardia regardless if it's malignant hyperthermia, because they're bleeding. You're cutting them up. So yes, there will be tachycardia. So I'm more biased toward unexplained hypercarbia, because it doesn't make sense. This patient is intubated, right? Because they're receiving general anesthesia. You're giving them muscle paralyzer. They're paralyzed. They can't breathe. So they're intubated. They're put on a ventilator. How are they going to have hypercarbia when you have high oxygen blowing into that lung, right? So the more sensitive indicator here is unexplained hypercarbia right here. Hypercarbia is the most sensitive indicator, because tachycardia is gonna occur the moment you cut this patient the first time. That's stress, so that will increase, trigger sympathetic response. Heart rate's gonna be high anyway. So it's really the hypercarbia, because that one doesn't make sense. Why would there be hypercarbia? You have a patient on a ventilator. So if you were to prioritize the symptoms, really it's the hypercarbia. So you see end-tidal CO2 going up. Well, I'll explain end-tidal CO2 another time under under oxygenation module. But anyway, the end-tidal CO2 level rises, and then there's muscle rigidity. In fact, if you let's say clown around and then lift up this patient's leg, it will stay up. It will not go back down. And if you put this patient's arm up, it will stay up. They cannot put it down. That's how rigid these muscles. And as I already mentioned, the hyperthermia is really a late sign. That's later, right? Because the after all these other events occur, then the if the muscle contraction has been on for 10-15 minutes, then you'll see the temperature rise. So if you look at if you test the patient's urine, because they may have a Foley at this point, for general anesthesia, then they'll have it'll be positive for myoglobin, plus the evidence of your acute kidney injury, of course, is the dark urine. So before we go to management, Is it easy to manage the complications I just mentioned? Acidosis, um, hyperkalemia, acute kidney injury. Are these
No,
easy to manage? No?
no.
Plus, this patient is in the operating room. By the way, I forgot to mention, when does this occur? Well, if you're lucky, it will start right during anesthesia induction, meaning we haven't even cut the patient open yet. The reaction starts. Or the worst case is this can also begin right in the middle of surgery when all the guts are out. Say this patient has open heart surgery. We're right in the middle of it, and then this thing occurs, surprise, this would be a disaster. Right? So the best time for this to occur is right in this at the start, right after we intubate the patient and then we give the anesthesia. It starts, at least we haven't cut the patient up yet. We can obviously stop the surgery. But if it happens right in the middle, that's a different story. So to avoid all this, we should have done this before surgery. So an important nursing responsibility here is to screen the patient. We don't routinely draw blood to check for the gene. That's a very expensive test. Plus, again, the rarity of this disorder makes it really impractical to test everybody for the gene. So what we'll do is just simply include it in the pre-op checklist. So in the pre-op checklist, there are 2 questions there. Have you had anesthesia before? If they say yes, another question will pop up. What reaction did you have? If they say yes, that they had a reaction, or a family member, let's say a sister, a brother, a dad, a granddad, because it's genetic. So it doesn't have to be them, or maybe this is their first surgery. So you'll be asking them a history. Did you or any family member have any reaction? Chances are they won't know what happened because all of these, occur in the OR, and then long story short, what they'll do is just stamp you as allergic to general anesthesia. Well, it doesn't really matter at this point if they say yes, a dad or something, because that's already a high risk, right? So we don't know exactly your question. We don't know what that reaction is. Are you going to take a chance? No. So what they'll do is not use the usual anesthetic drugs, including succinylcholine. We'll use something else. There are other options. There are other drugs not known to be associated with malignant hyperthermia. Is that clear? So this is your job as a pre-op nurse. You do your checklist, especially if they're undergoing general anesthesia. Then you ask, did you, or plus it's already included in the checklist. You have to memorize it. It's in your checklist. So you just need to do your job. Ask the damn questions. Did you or a family member have any reaction? The answer is yes. There's another question that says, what kind of reaction was it? If they don't know, doesn't matter. That information is in the system. That's the cue. So for the anesthesiologist, he sees it. There's a yes answer. He won't take any chances. Okay, he'll say, oh, okay, so this is possible MH. So no halothane, no succinylcholine. All right, clear? Any questions, team nurses?
No.
All right, so once here, stated here, all patients should be asked, and then they'll be cautioned to wear a bracelet. Okay, the bracelet will, of course, say they're allergic to general anesthesia. Then they'll use something else. Doesn't mean they won't have surgery. Of course, they need surgery, but we'll just avoid the drugs known to trigger malignant hyperthermia. So here, without quick and appropriate treatment, these patients die. I mean, you saw what, that I described, what could be consequences. There are many possible causes of death. The treatment is dantrolene sodium. It's the only FDA approved. It's a muscle relaxant. So if we stop the muscle rigidity, really all these things happen because of the muscle rigidity, right? That's the cause of the acidosis, the hypercarbia, the hyperkalemia, and then the myoglobinuria, which led to your acute kidney injury. So if we stop the muscle contraction, the muscle rigidity, then there will be no complications. So if we see the signs, if possible, we stop the surgery if we still can, and then administer the drug, and then we start cooling the patient. Because even if you were able to stop it, it did begin, it was triggered, so the temperature will rise regardless. So now you start cooling the patient. Cooling here will not be limited to external cooling, so not just ice bags on the armpit, the neck, or the groin. They will have to be cooled from the inside as well. So all IV fluids here will be wrapped in ice so that when they enter the body, it's ice cold. We will also, if possible, we will also lavage the stomach. We put iced, cold water into the stomach, literally cooling you inside. So we have ice saline, we have lavage of the GI system with cold water. We can even do enemas. So enema, also using cold water enema. We could put in a bladder irrigation, also called using ice saline to irrigate your bladder. You have a question?
Isn't there a danger to cooling off the body too rapidly from
Not with this one. Not with this one. Yeah, this is, malignant hyperthermia. I mean, 111.
bringing it down too rapidly?
I know we will stop at a point. I think it's 102. Once we reach 102, we stop because 102. The body can take care of that. But 111, the body's cooling mechanisms fail. They can't do that on its own. So you have to help it out. So here, so remove blankets, expose them, cold NS, ice bags, and lavage. So pretty much cool every body cavity, the bladder, the GI tract, the stomach, the IV. And that's pretty much it. So if this patient survives, then definitely they'll be stamped as allergic to anesthesia. Don't give them that again. We don't want this trouble in the future. And that's it. Questions?
Let's say if they die from this, can their organs be donated and utilized?
Yan, your audio was cutting out. I can't hear the full sentences.
I'll email you.
Okay, all right.
Professor, do you have one more question?
Yeah.
So instead of regular anesthesia, what medicine would you like to give them? Like what other anesthetics?
Oh, there are other inhaled anesthetics other than the ensiflurine. They're more expensive, but it's worth it.
So can you just not take the risk and just go ahead and take the expensive one?
The insurance company won't pay for it. Yeah. Again, it's rare, okay? Yeah, I mean, I've worked in the OR for a short time. I didn't like it, but there's a kit there. Every OR, it's required by Joint Commission that every OR has a malignant hyperthermia kit. Those kits expire repeatedly. They never get to use it. But it's required. You have to have one because, I mean, what are you going to do if this happens? You have to have a kit, right? It's like a crash cart. So the kit is labeled malignant hyperthermia. It has a expiration date on it. So anytime we need it, it's there. What's in it? Definitely we have dantrolene sodium. What else? What other problems occur there? We have the hyperkalemia, right? So what do you think we'll have in that kit for hyperkalemia? All of those, calcium gluconate. We have dextrose with insulin. Yeah, we have insulin there, regular insulin. What else? We have Lasix there. So everything you need will be in there except the ice because we can't put ice in there. It's gonna melt. You're gonna have to get the ice somewhere.
The ice is not in the room.
No, it's not in the kit.
Okay, sorry.
Well, somewhere in the cafeteria, there's an ice maker bound to be in the OR, right? But you know what I'm saying? Okay, so there's a malignant hyperthermic kit on standby in every operating room. Doesn't mean we get to use it a lot. I mean, you can ask any OR nurse how many times they've had malignant hyperthermia. Probably some will say never. Um, it's extremely rare because, again, our screening works. Meaning, if the patient says yes to that question that they had a general anesthesia reaction, them or a family member, then we won't use it. No, we'll take the precautions. Does that make sense? Yeah, that's why it's extremely rare because, again, our screening questions is effective. They've been effective, except of course in the cases of family members who have no idea. I mean, they don't have any history for their parents or their grandparents, and this is the first time they're having surgery. So those will be the rare ones that, I mean, what have you to go with? We have no history. Okay, let's go to 1562 now. Let's begin with hypothermia. Sorry, 1562. All right. So we started with hyperthermia. Let's look at the other problems now related to thermoregulation still. So our thermostat is the hypothalamus. It sets a certain temperature from which our body will adjust up or down to stay close to the set temperature. So just like the cooling system in your house, your AC maybe set at 78, for instance, all throughout the year. That's a nice, comfortable temperature, right? For the body, what is our normal thermostat? Where should we be at? What's a normal body temperature? 97 point what? Okay, right here, 98.6, more or less, right? So we try to stay right there. So that's where your hypothalamus will set the temperature. Of course, the temperature never stays there because we're exposed to cold, or let's say you're exercising, so temperature changes. So we'll have to make heat loss and heat generation mechanism. So heat loss, we perspire. We what else do we do if we're hot? Yeah, we perspire. Yeah, we have vasodilation.
Sweating.
Yeah. Okay. So anyway, basically we this is our set thermostat, and then our body has to adjust to that to maintain that temperature. So we have heat loss mechanisms, evaporation, convection. We put on a cold towel, for instance, or no, that's conduction. And then we have convection. We fan ourselves or take off our clothes so we can have breeze in, or um, crank up the AC. And then in the case of if we're too cold, if we go hypothermic below 98.6, then we shiver and we put on warm clothing, or we sit by the fire. Okay. So these are our heat loss mechanisms here. Let's talk about hypothermia. So we had a little bit of hyperthermia. So let's do hypothermia first, and then later we'll go to hyperthermia again. So hypo is definitely below what temperature? What is the definition? Below between 89.6 to 95 degrees. So this is mild hypothermia, and then it'll be much lower when we get to moderate. Here, moderate is already 82.18.4 to 89.6, and then we have severe, less than 82.4. Before that, let's look at the risk factors first. So this would be a very good select all that apply question. So who are at risk for hypothermia? One is age. What else? Medical conditions, such as, for instance, if you have neuropathy, for instance, or let's say this patient has any cognitive problems. Let's say people with dementia, are they able to tell that, no, it's dangerous to be out there? No, right? So we have, what about other impaired individuals? Let's say mental retardation, for instance. Or just simply drunk, right? So old adults, these are the risk factors, and then the very young, because of their structure, we have more. Here's the rationale for the children, and then we have through their head again, because their heads are bigger than the rest of their body, especially babies, right? Or just poor judgment and less efficient mechanisms for generating heat. And then here are the psych problems that could lead to that. So dementia, or if you're under the influence, for instance, of either alcohol or drugs, and etc. So here are your mild, moderate, and severe. I won't read the paragraphs for you. Please read the effects on your own for each level. How is this asked on the exam? We begin with the temperature. So what level constitutes mild, moderate, and severe? Next are the signs and symptoms of the patient with mild, moderate, and severe hypothermia. So that's your homework. Treatment. You can disregard the questions. I mean, these are standard questions we ask. Plus, it will be mentioned again under nursing care. Let's go to our interventions. And here are the laboratory findings. We start with external warming. So let's say it's winter, which is the most common time we get these cold exposures. So we're talking about homeless people or drunk homeless people, for instance, or just drunk people out there with very little or not clothed enough. So once you find them, ABCs in all situations, that would include inserting a line and then start fluids. If we gave fluids which were cold in malignant hyperthermia, what do you think we'll do to these IV bags? Okay, warm them up. Put them in the microwave.
It's already warm in the fridge.
I mean, this is hypothermia. So I'm asking, can you put them in the microwave? No, of course not. All right. Yeah, either room temperature, okay, or you can also wrap it with what are those hot things? Hot packs? Yeah, something like that. Okay. Hmm? In the refrigerator? It's not gonna cool it then. Okay. Yeah, and said it twice too. All right, so we'll do passive first, and then active external warming, rewarming as well. And then, especially for moderate to severe, we're doing internal warming. We'll get to that shortly. So here are your rewarming strategies, whichever is applicable, depending on the level of hypothermia, whether it's mild, moderate, or severe. For mild, we don't have to do internal warming. We just do external, just give them blankets, warm blankets. And for moderate, you can start doing the electric blankets, warmers. Have you seen those? They can also be used as cooling blankets because it really depends on the temperature of the water that you put in it. Because it circulates water, they have tubes inside that big sheet, and then it just depends what temperature water do you put there. You can put cold or you can put warm water in there, and then you put it on the patient. So those are what do you call them? Warming blankets. Yeah, warming blankets. Yeah. Or if it's the opposite, then it'll be cooling blankets. Yeah. So here are your passive, and then we have your active rewarming strategies, all external, and then here are your options for internal. So warmed IV fluids, warmed oxygen, including your humidifiers as well. The humidifiers will also be warmed. That way the oxygen as it enters is already warm. And just like what we did earlier for the patient with malignant hyperthermia, we warm them inside all body cavities. So we put it in the bladder, in the stomach. This is already invasive in patients with, this is probably in like frostbite or severe hypothermia. There's no way for you to warm the body enough, even internal cooling methods. So we'll have to warm it in a machine. So Ecmo is typically reserved for children. We don't use it typically for adults. Ecmo is a cardiopulmonary bypass machine. The primary purpose of an Ecmo is really for oxygenation. You've heard about it, right? In COVID patients, wherein you intubate them because their lungs are so wet, you can't do oxygenation anymore. Their lungs are pretty much gone. So you're gonna oxygenate it through a machine now. So that's what Ecmo does. So if you can oxygenate the blood outside the body, you can also warm it outside the body using the same machine. So the blood enters the machine, warms it, and then returns it back to the body, warm already. Right? But that's last resort. Here, this is the preferred method for rewarming cardiac arrest patient. Let's talk about CPR, because most patients in severe hypothermia go into cardiac arrest. We extend the chest compression time beyond what's expected in all other people. We can do, what's the time here? I know that's for checking your pulselessness. Looking for the time. But anyway, so let's say in CPR, we stop around 10 minutes. So this one, in a patient who had a hypothermic cardiac arrest, we extend it to double the time. The reason is the saying goes, you're not dead until you're warm and dead. You're not dead until you're warm and dead. Yeah, because a hypothermic heart is not going to circulate blood correctly. So you need to, you can't basically, what I'm saying is the doctor can't declare you dead until you reach a certain temperature. And then you're dead, then you're definitely dead. Does that make sense? Okay. Right here. So defibrillation is difficult if the body temperature is low. So further attempts are deferred until temperature, at least when you're at least 86 degrees, then we can probably stop. All right. But if you're below that and there's no, electrical activity, we just continue CPR. Right. You keep giving CPR until you reach 86 core temperature. And you do realize, right, that why do we do CPR? And why does CPR restore a cardiac rhythm? Because let's say a systole, right? No electrical activity. Why are you doing CPR? Okay, so it's really the action of the blood circulating, and then once blood circulates, of course, you're pushing electrolytes in and out of the cell. So unless there are electrolytes going in and out of the cell, there will be no electrical activity. So technically CPR, the chest compressions are going to generate an electrical impulse. So hopefully that will eventually get the heart moving again, because now you're generating electrical impulses. So that's why you don't shock a person with a systole, because there is no electrical activity. All you're doing is cooking the patient. So if you deliver an electric shock in a systole, you're like barbecuing the patient. Does that make sense? Yeah. Okay. So rewarm. Regarding rewarming, which part of the body should you rewarm first? Okay, rewarm the core first. So since you said legs, please read after drop. So what is after drop?
After drop is defined as a reduction in core temperature due to redistribution of body heat to improperly warmed peripheral tissues with rapid shunting of cold blood from the periphery to the core as the direct result of vasodilation. This causes a bolus of cold, hyperkalemic, acidotic blood to return from the periphery to the heart, which results in biochemical injury that leads to severe hypotension and dysrhythmias. Rewarming the core at a prescribed rate is important to prevent significant complications.
All right, we're clear on that, right? So rewarm. Don't worry about the extremities. If you see, what is that? No, the what do you call that when it's frostbite? Don't worry, frostbite is frostbite. I mean, you can't resurrect that. Okay, those tissues are dead. So focus on the core. So rewarm the core. You save the patient exactly for this reason. We don't want hyperkalemia and acidosis to cause the cardiac arrest. So core, and then we'll worry about the periphery later. Yes, we will take care of the frostbitten areas, but later our priority is the core. Okay, so save the patient, stabilize their blood pressure, their temperature, and then we'll treat the frostbites. Okay, because they're already frostbitten. You can't. I mean, what are you gonna do with the frostbitten leg? Yeah, it'll fall off on its own. No, I'm just kidding. Here's an evidence-based practice. Please read it on your own. It's not really on the exam, but it's a nice thought. If you read this, it's very interesting that they're doing therapeutic hypothermia. So they're doing this on purpose here, reducing body temperature will reduce a cerebral metabolic rate, reducing the risk of brain injury. We'll explain this again when we get to head injury under intracranial regulation. I don't know which module that is, but we'll discuss this, okay, as part of interventions for traumatic brain injury. And that's it for hypothermia. These are your summary, your IV again, and then your rewarming measures, external, and then you do internal. Teachings, of course, will be prevention of the whole event in the first place. Questions on hypothermia? Let's go back again to hyperthermia. So we kind of saw it in malignant hyperthermia, although we looked at a really life-threatening scenario. This one, let's look at hyperthermia, except malignant hyperthermia. So what's the difference between hyperthermia and fever? Is it the same? Donna, you shake your head. What's the difference between fever and hyperthermia?
You can treat fever with like
And you can't treat hyperthermia?
you can, but you have to go.
So that's not the difference. So what's the difference between fever and hyperthermia? Both are hot. Yeah, both patients are hot.
Duration.
Okay, that's one difference.
Hypothermia is higher.
Yes, go ahead, Yan.
Hypothermia is higher.
Hyperthermia, the temperature is 104. And fever is 102, something like that. It's lower.
Okay. All right, so the difference between fever and hyperthermia is the thermostat. It's the set point. Remember I told you, I talked about the hypothalamus at the start earlier? That the hypothalamus sets a set point for your body temperature, which is 98.6, right? Yeah?
Right.
Okay. So the difference here is in fever, the patient's set point changes. The change is caused by the pyrogen. So whatever fever-inducing organism entered your body caused the infection, it made the hypothalamus change the set point. So instead of 98.6, now the set point is now maybe 101 or 102, which is way higher. So as a result, the body has to generate heat, right, in order to reach that new set point, because the hypothalamus erroneously, as again, if as caused by the pyrogen, changed the thermostat set point. So instead of at 98.6, it set it at 101 or maybe higher. So now the body is forced to generate heat in order to reach the new set point. Does that make sense? Now in hyperthermia, the set point remained the same. There is no organism here, there's no infection causing the set point to change. Your set point or your thermostat remained at 98.6. But look at the causes of hyperthermia. What caused the temperature rise? Is it the change in the set point? No, this is caused either by an external environmental factor, or the patient may be also generating the heat, usually caused by exertion. Because remember, when you're, or both, it could be both. For instance, if you are, it's 120 degrees in Arizona, then you go out and mow that yard, or you go out for your usual jog, okay, because you're very conscious about being fit. 120 degrees, you still went out and jogged for 5 miles. Jogging generates heat plus the 120-degree environmental temperature. What do you think is going to happen?
Heat stroke.
Okay, let's distinguish first between heat stroke and heat exhaustion. Heat stroke is different because this is now a medical emergency. So let's do the less lethal first. So let's do with hyperthermia, which is pretty much heat exhaustion. Heat exhaustion is a milder form. It's basically dehydration, meaning you're either out mowing the yard or running a marathon under 110-degree heat, and you basically became dehydrated. Those are your signs and symptoms. So what are signs and symptoms of dehydration?
Be thirsty.
Okay, what else? Heart rate will be tachycardia and blood pressure.
Hypotension.
Okay, hypotension. Hematocrit will be increased.
Increase.
Urine output will be and urine specific gravity will be okay. Very good. So all of those symptoms, okay, symptoms consistent with dehydration. Heat stroke has all the signs and symptoms of dehydration plus mental status changes now. Because in heat stroke, the patient, unlike in heat exhaustion, was still able to lose heat, meaning they still perspire, they still have the thirst mechanism. In heat stroke, that's all gone. The patient's heat loss mechanisms fail. Yeah, no more sweating, and cognitive changes already is there. So are you aware that you're even in trouble, that you're thirsty? No more. So that's what makes heat stroke a true medical emergency. Patients have no idea they're about to die. Here are your risk factors. Age, similar to hypothermia, and drugs, so about the same. You can read these, but I'm not really testing heat stress, heat edema, and heat cramps. So here is heat exhaustion and heat stroke, as I am testing both. So look at these signs and symptoms. Pretty much these are dehydrated patients along with some electrolyte imbalances. Here, no significant neurologic impairment. Patient's mental status is intact. They're completely aware. Temperature is between 100.4 to, I guess, 103.9. Heat stroke, the temperature, because it's really the mental status change here is caused by the extreme body temperature rise. Once you hit 104, I mean, what's happening to your brain tissue now? It's cooking. Yeah, you're literally cooking your brain. So can you think clearly? No more. So you go cuckoo. You very confused. Your brain pretty much is cooking at that temperature. And then this will now lead to these complications here. So remember, hemoglobin, or rather oxygen, does not stick very well to hemoglobin if you're in severe hyperthermia, or at least in acidosis, because there's acidosis here, right? When tissues start to die because of the high temperature, now you have acidosis, hyperkalemia, and hypoxia and hypercarbia at the same time. So of course you'll be confused. Here, the oxygen carrying myoglobin potentially precipitating renal failure at the same time. So you saw that in malignant hyperthermia. And then death will follow. Management. So you already saw the cooling measures, so this will go faster. You already cooled down the patient in malignant hyperthermia. So if we're dealing with heat stroke, those will be the same heat loss mechanisms or heat loss interventions, cooling interventions we will do, external and then internal cooling measures at the same time. However, if it's heat exhaustion, which is basically dehydration, we will just simply take off their clothes and move them to a cooler environment. That would be your priority, and then start replacing fluids. Patient has hypotension, so how do you position them before we reach the hospital? What do we call that when you keep the head flat with the legs elevated, Donna? What was that?
When we trend it.
Well, if we do Trendelenburg, then the whole body is upside down or tilted down. The body is flat, only the legs are elevated. What do you call that? That's modified Trendelenburg. All right, so we put them in a modified Trendelenburg. Is venous return, increasing cardiac output. So look at your interventions here. They are basically dehydration interventions. So you do oral or IV fluids or fluid replacement. So why sports drinks? Why are these best? Sports drinks, fruit juices.
The electrolytes.
All right, because they not only water, they also contain electrolytes. Okay. And then, as earlier, ice packs, fan the patient, saline if they can't do oral fluid replacement. Here, I think I mentioned this earlier. When do we stop? Okay, so our intervention should stop, the aggressive cooling interventions should stop around 102. You may wonder why 102? Okay, why can't we? Because that's not normal either. 102 is still high. Why do we stop there? Plus, what can you say about the level 102? Because remember, this is hyperthermia. Our set point is 98.6. Can we handle 102 now? Yeah. Yes. So your body is able, we can handle this. We'll take it from here. All right. So that's basically what your body will say. So you give it help up until 102. Because if you keep interventions down here, it will become counterproductive. Remember, the heat loss mechanisms failed after 102. Now we're back to 102. Are the heat loss mechanisms intact? Can it function now? Yes. Remember, yes, if you can, because the consequence is if you continue your cooling measures, what do you think the body will do as a response? If you keep the ice going, the cooling blankets, what will the body do?
Try to generate more heat.
It will start generating heat now. It will now respond by shivering. So it's time to stop. Once you hit 102, that's enough. Because now we may trigger shivering, which will drive up our body temperature again. Is that clear? So you do all these interventions here up until 102. Now remember, we're only talking about hyperthermia here, not fever. If fever caused by illness, we continue the cooling measures. Is that clear? Okay, so these interventions here, we are under hyperthermia. We are not talking about fever. Is that clear? All right. This is only for hyperthermia. In fever caused by illness, of course, 102 is pretty high. We continue our cooling measures. Because remember, in fever, did the set point change? No. Yes, it did. Yeah, the organism, the virus or the bacteria change the set point. Does that make sense? I mean, your set point is now 101. Do you think the body will drop below 101? No, it will stay at 101 because that's the new set point caused by the virus or the infection. So until that set point goes back to 98.6, you have to continue your cooling measures, right?
So at that point, like NSAIDs or nothing else would work. You still need to cool them, like the ice.
Yes, because in hyperthermia, remember, the set point never changed.
Yeah.
The set point remained at 98.6. It's really the body's heat loss mechanisms that failed because we went beyond 104. But once we start doing the cooling interventions and we reach 102, this is hyperthermia, so we can stop here now because the body can take it from there. So now we can do just fluids, for instance, and then that temperature will eventually drop down. And that's about it. Please read the nursing summary on your own. They're repeated already. And that concludes thermal regulation problems. And